Well, I thank you all for attending this meeting. It's an honor for me to be here and tell you the story of how our laboratory in Louisville, Kentucky responded to the pandemic using the ARIES instrument. What I wanted to do to start with is give you a little bit of background about our laboratory so that you can have a sense of why our laboratory chose to use the ARIES and the reasons behind why this has made us successful in responding to the pandemic. So I'm going to start by showing you a picture of our original team. We started using the ARIES system back in 2016, so I call this our original team. Laura Schindler is to the left. She is our diagnostic laboratory manager with over 30 years of experience. Sabrina Gar is next to her, and she is our senior medical technologist, again, with over 20 years of diagnostic laboratory experience. I am in the center. Jennifer Wick is one of our medical lab technologists, and Dr. Subi is our research laboratory director who has a PhD in biochemistry and ASCP certification in molecular biology, and she has been really a godsend in helping us bring up assays on the ARIES instrument. So that's our team at the University of Louisville Infectious Diseases Laboratory. Just so you have a sense of who my team is and why I'm fortunate enough to be able to do things like this, because they do such an excellent job holding down the fort in the laboratory. So a little history of our laboratory, because it is unique. It was founded in 1971 by Dr. Martin Raff, a faculty member at the University of Louisville. And in 1990, when CLIA-88 came into full effect, Dr. James Summersgill was the director, so we became CLIA-certified under his direction. The Infectious Diseases Laboratory is a university-based, high-complexity CLIA-88 certified laboratory. We are not affiliated with University Hospital or any other hospitals in the Louisville area. The mission of our laboratory has always been to provide reference laboratory testing that is both timely and accurate for the greater Louisville area and southern Indiana community, which makes up about 1 million people. We provide testing services to our local hospitals, medical centers, clinics, private physician practices, and we focus on diagnosing infectious diseases. Because we are a local resource to 4 major hospital systems in our area, this includes the University of Louisville Hospital, Norton Healthcare System, Baptist Healthcare System, and a VA medical center, we can often pick up samples daily for those hospitals that are within walking distance. We offer a rapid turnaround time, and we can quickly adjust to the testing needs of our community because we're a part of it. So these efficiencies and strong relationships allow us to communicate with healthcare providers more quickly, and then in turn that allows them to make patient management decisions and treatment decisions more quickly based on our laboratory test results. As I mentioned, we primarily serve as a reference laboratory in our region of Kentucky and southern Indiana, and we really specialize in niche testing for atypical pneumonia and tick-borne diseases, which I'll describe a little bit more in detail later. But we rely heavily on molecular diagnostics to detect respiratory infections with organisms that are historically difficult to grow in culture, such as Legionella pneumophila, Chlamydia pneumoniae, Mycoplasma pneumoniae, and most recently Pneumocystis jirovecii. We use a combination of serological and molecular diagnostic tests for tick-borne diseases. And we tailor these to tick-borne diseases that we would find endemic to Kentucky. Serological assays we use are for the detection of both IgM and IgG antibodies that are indicative of Lyme disease and spotted fever group and typhus group rickettsiosis. Molecular diagnostics, however, are really better suited for detection of infections with Ehrlichia species. And although our assay covers Ehrlichia chapiensis, E. ewingi, E. mirus, and the newest E. oeclarensis, Really, we see E. chapiensis most often in our area. We also test for anaplasma phagocytophilum, even though we haven't seen cases in Kentucky or acquired in Kentucky. All of the states around us have reported cases, so we continue to test for that in our PCR assay. The sample type we use are whole blood from symptomatic patients with histories of tick bites. So the other half of our laboratory is a research component. I've described our diagnostic laboratory, and I want to tell you a little bit about our biorepository activities. So our PhD biochemist with a specialty in molecular biology is our research laboratory manager. In addition to her, we have 3 full-time staff members that help manage the biorepository. In the biobank, specimens are collected under university-approved protocols from enrolled and consented patients and stored for clinical research purposes. The sample types include urine, stool, both upper and lower respiratory tract specimens, whole blood, plasma, and serum. In support of various studies, staff members may perform antigen tests, PCR assays, and even biomarker studies on some of these specimen types. Bacterial isolates such as Streptococcus pneumoniae from patients with community-acquired pneumonia have been archived for epidemiologic studies in support of vaccine development. What is really unique about our division's biobank is the availability of associated clinical information with all these specimens that have been archived in long-term storage in ultra-low freezers that are also on emergency generator. More than 60,000 specimens are maintained in these ultra-low freezers, and all data associated with the specimens is entered into REDCap, a web-based database with a high degree of flexibility. In fact, REDCap is the lab information management tool we use in our diagnostic laboratory as well, so it makes cross-training a little bit easier. So I wanted to give you a sense of the size of the laboratory based on our test volume. So these 2 panels include the molecular diagnostics that we perform on the ARIES instrument. So for our tick-borne disease panel, in the year 2019, the most recent year that I have all the data for, we did almost 1,200 Ehrlichia tests on whole blood specimens, and because it's a duplex assay, we also included anaplasma phagocytophilum. We performed a lot of spotted fever group and typhus group rickettsial serologies, both IgM and IgG, in the same amount. And then we performed the Lyme disease screen, which is an enzyme immunoassay. And at that time, we were performing Western blots to confirm. So that's the reason that the number is smaller for the reflex test. In the atypical pneumonia panel, we did a little over 600 tests in a year for mycoplasma, chlamydia, and legionella. Because this was a late addition to our menu, the pneumocystis cerevisiae numbers are quite low, of only 24 that particular year. But I wanted to note that because some other assays that our hospital use include mycoplasma and chlamydia, but not legionella, we get a lot of requests for legionella and pneumophila only on lower respiratory tract specimens. So based on this data, I would say we're a small to moderate size laboratory. Another reason the ID laboratory chose to go with the Luminex ARIES back in 2016 had other factors. Staffing. So I showed you a picture of who we had on board at that time. We had myself as a CLIA qualified director with a background in microbiology, immunology, and molecular diagnostics, a CLIA laboratory manager with 30 years of diagnostic lab experience, our research laboratory manager, Dr. Subi, and we had a senior and a junior laboratory technologist to help us. So not a huge laboratory, in fact, quite small. At this time, we were in a very, very cramped laboratory space, and so we had limited room to grow with increasing test menu. So the size of the ARIES was amenable to the space that we had at the time. Our test volume, showing you our molecular data, it would be moderate to lower volume. We're not a high volume, high capacity laboratory. With the limited space available, we wanted to reduce the requirement for multiple steps. So we wanted to eliminate the separate extraction, PCR and detection, and we really were looking for a sample to answer solution for our laboratory. Historically, our laboratory has provided same day or next day results upon receiving the specimens, and we wanted to maintain that turnaround time. And so the ARIES has about a 2-hour process time once it's on board. In addition, because our laboratory was small, we wanted to make sure we had support for doing laboratory developed tests because we are a niche laboratory. So knowing that the vendor we chose had a tech support team was really a critical decision point as well. So the ARIES, for all these reasons, turned out to be the best solution for our laboratory back in 2016. As I mentioned, back in 2016, we're in a very cramped space. In between that point and early 2017, we moved to a slightly less cramped laboratory space. And I'm happy to report in October 2020, we moved to a actually fantastic laboratory space. And so we've been able to grow from our original 2 M12 ARIES to add an additional M6 and 2 more M12s in response to the pandemic. And so we have space for all of our instruments, which makes us very happy. I wanted to step back a moment now and switch gears to really talk about how the ARIES system helped us respond to the pandemic. So I want to take a step back and review the timeline from where this started to where we are now. So in December 31st, 2019, the first cluster of pneumonia cases due to an unknown cause occurred in Wuhan, China. By January 11th of 2020, the first death in China was reported. Within 2 weeks, cases outside of China were reported, and January 21st, the first case in the US was identified in Washington State. By the end of January, the WHO had declared a global health emergency due to this novel coronavirus. And February 2nd, the first death outside of China was reported in the Philippines. Later in February, on leap year day, the first death was reported in the United States. Because of some issues with the original test developed by the CDC and provided to public health laboratories, there was some delay in the amount of testing that was available in the United States, which led the federal government, the FDA, HHS, to lift the normal restrictions they would put into place with emergency use authorization testing. So these restrictions were lifted to allow more laboratories to perform COVID testing. On March 13th, the US declared a national emergency due to COVID-19. And unfortunately, by March 26th of 2020, the US was leading the world in the number of confirmed cases. I thought it was interesting to note that April 21st, California discovered that 2 patients had died of COVID-19 in February 2020 based on autopsy results. So the disease was actually here a little earlier than we all had imagined. And one of the major points in time was by May 27th of 2020, the US deaths due to COVID-19 reached a critical point of 100,000. And then September 22nd, we crossed another milestone of having 200 deaths due to COVID. So how did the ARIES help us in Louisville, Kentucky respond to COVID-19? As I mentioned, we've had past experience with implementing laboratory developed tests on the ARIES platform, such as the atypical pneumonia panel and the tick-borne disease panel that included Ehrlichia and Anaplasma. And we had guidance from Luminex technical support team members. We have 2 PhD staff members on our team with experience in molecular biology and 3 medical technologists who also had gained molecular biology experience over time. We were able to purchase additional ARIES instruments. We were able to cross-train staff in the biorepository, which is part of the reason I told you about that. We were able to pull staff from that because some of our research studies slowed down during the height of the pandemic. And we were actually approved to hire 3 additional temporary laboratory staff to help with evening and weekend shifts, which was new for the infectious disease laboratory. Prior to this pandemic, we were pretty much a 7 to 5 a.m. Monday through Friday laboratory. But with the volume of testing that we were trying to provide to our community and to our partners, we had to extend our day from 7 to 9 Monday through Sunday, 7 days a week, to provide the timely testing that we wanted to provide to hospital systems in particular. So part of the way ARIES helped us respond to COVID-19 was allowing us to use a lab-developed test and follow the FDA's template for emergency use authorization of a molecular diagnostic test. So following this timeline, on March 11th, we notified the FDA of our intent to submit a data packet for emergency use authorization of a CDC-modified PCR on the ARIES instrument. We were allowed to do diagnostic testing during this 15-day period when we completed our data packet. And at that time, because of the limitation, we used G-blocks of the coronavirus genetic information and contrived clinical samples because that's all we had available to us. By March 27th of 2020, we began testing healthcare workers for a large local hospital system in the Louisville area. After submitting our packet, we had a call back from the FDA on April 9th talking about a bridging study that we should do with viral RNA to replace the G-block data. As more and more samples were becoming available, they felt like this was a reasonable request. Around that same time, multiple laboratories were experiencing the lab supply chain issues. And so we let the FDA know that repeating some of this data was challenging because we were weekly dealing with a problem of getting carrier RNA or viral transport medium swabs or some component of the testing process. And so we let them know that it was taking a little bit longer, and we were also having trouble finding stable quantitative control materials. May 21st, again, we notified them of a shortage of testing supplies due to plasticware. And on July 2nd, the FDA notified our lab that we basically needed to repeat the whole validation study with patient samples and not spike samples as we had done back in March of 2020. The reason was they were seeing performance issues with PCR assays that had been approved early on using contrived or spiked samples and weren't performing as well with clinical specimens. So they wanted us to repeat it with patient samples. So a couple of weeks later, after repeating all this, we submitted our revised data packet with new limit of detection studies and additional clinical validation data using samples that were shared by the Louisville Metro Public Health Laboratory. On August 31st, we submitted a data packet with a pooling scheme and protocol, and I'll talk a little bit more about that process as well. So unfortunately, what we learned this month after preparing this slide set is due to the number of manufacturer test kits and systems available through the EUA process, the FDA is no longer reviewing our data packet since it's a laboratory developed test. They have limited resources, so basically after all this work, the FDA has declined to review all of our data. So I wanted to show you again pictures of our ARIES instruments. We like to name our instruments. It makes us happy, and we think it makes the instruments happier. They feel like part of our laboratory. We're also all fans of Dr. Seuss, so we've named 2 of our M12s Thing 1 and Thing 2. The ones we brought as part of a response to the pandemic are Redfish and Bluefish, which you can see here. The M6 we have, which is smaller, we got in the habit of calling ARIES Junior, so his name is AJ. So I just thought that might be a helpful hint to name your instruments because it makes people happy, and the instruments are happy as well. So getting back to how the ARIES helped us respond to COVID-19, we had a changing population that we were offering tests to. And it was really based on the priorities of our hospital clients and what was happening in Kentucky. So between March 11th and March 26th, we were actually part of a public health surveillance project with a research laboratory here at the University of Louisville, the Center for Predictive Medicine. They were using the CDC assay available at the time, which had N1, N2, N3, and RNase-P as the targets. Theirs was a high throughput setup, so they were doing a separate extraction and then a separate PCR detection. So we compared samples during this time from a healthcare system to make sure that our tests were performing similarly. And we found 100% agreement, which gave us a lot of confidence for our diagnostic testing and for their surveillance testing. We officially began diagnostic testing on healthcare workers for our local hospital system because they were a high priority early on in the pandemic. We were at the highest risk, taking care of ill patients. And with respiratory protection being somewhat of a limiting factor, everyone was really focused on testing healthcare workers. Between July and September, we began testing inpatients for the same hospital system because the hospitals were starting to open up at this time. They were starting to reschedule preoperative appointments for people that had been postponed due to COVID-19, but really needed to be taken care of. So that's what we focused on July through September. At the same time, we also had requests from some of the large private companies and employers here in Louisville, dental offices, which had also started opening, and some other elective surgery patients that were preoperative and coming through our division's travel clinic, which had been repurposed during the pandemic to help get patients seen that needed a test to be cleared for, as I said, preoperative surgery, dental appointments, etc. By October, our priority had shifted to nursing home staff. So currently our main population we're testing are nursing home staff weekly as part of a surveillance plan for the Kentucky Department of Public Health. So just to give you an idea, as our population we were testing changed based on the needs of the community, between March 27th, when we officially started doing diagnostic testing, and October 9th, which is when I captured the data for this presentation, we had performed almost 11,800 COVID-19 tests using the ARIES system. We had over 1,000 positive results, giving us an 8.64% positivity rate. And I will tell you that even though our population shifted, I would say it wasn't until we shifted to nursing home staff that we were still seeing in many of the different populations we tested well over a 10% positivity rate. So I wanted to go through a little bit of the technical work we did for the FDA EUA process. And I have it divided into part one, which is the early part when we were working out the original guidance from FDA. So we used G blocks, which were pieces of the coronavirus in DNA form to do limited detection studies. And we did this with 4 other sites who also were ARIES users. And G blocks were chosen because, again, early in March, there were a limited number of well-characterized clinical specimens or viral material available to us. So there's a white paper which you can find on the Luminex website that describes the data we gathered between our 4 laboratories. There was also in silico analysis done of the modified CDC primers that we used targeted to the N1 and N3 region of the SARS coronavirus 2. Exclusivity analysis ensured that our primers and probes did not pick up anything outside of the novel coronavirus, so there wasn't cross-reactivity with endemic coronaviruses, other viral or bacterial respiratory pathogens, and then also an in silico analysis of inclusivity. So of the SARS coronavirus sequences that had been shared, could we pick up all of them with our assay? And so the data showed that all of this looked great. We used spiked clinical samples to meet the FDA EUA requirements. We chose nasopharyngeal swabs as our specimen type because that was the gold standard. We also, per the FDA requirement, sent our first 5 positive and our first 5 negative nasopharyngeal specimens to Frankfort, Kentucky, where our public health laboratory is, the Kentucky Division of Laboratory Services. And fortunately, all of those 10 results agreed 100%. So that's how we were able to begin diagnostic testing. So in addition to the in silico analysis I told you about, we also had archived some specimens that were previously positive for other respiratory pathogens done using the BioFire film array. And we found no cross-reactivity with specimens positive for RSV, parainfluenza, rhinovirus or enterovirus, influenza A, B, or the 4 endemic coronaviruses. We spiked clinical samples to meet the requirements as well. So we had to do 30 negative clinical samples, and 100% of those results were negative as expected. 29 of our 30 expected positives were positive, which is a threshold acceptable to the FDA. So based on all this data, we submitted our packet on March 26th to the FDA for their review. So I called this part 2. This is after we had our phone calls with FDA, and they had changed their mind as to what would be required for reviewing our EUA submission. So we had a lot of conversations with them about the challenges of finding control materials that were suitable for repeating the limited detection study on the ARIES. So the benefit of the ARIES, as I mentioned, is it's a sample to answer system. Because of that, we knew from previous experiment that using extracted RNA resulted in loss of that RNA when you added it to the cassette originally as if it were a specimen. We just have found that over and over again. So you really need to start with something that's more like a clinical specimen. And unfortunately, a lot of the control materials at that time were not really well suited to a sample to answer system. The ones we tried had stability issues. While they worked well undiluted, when we started to dilute them for limited detection studies, there were stability issues. As I said, the sample to answer format precluded the use of extracted viral RNA. And then we also needed something inactivated because we were not a BSL-3 facility. So we needed something safe to handle at a BSL-2 level. So fortunately, with some time, Zeptometrics made available some heat inactivated viral culture material that was quantitated in the terms of viral culture, so tissue culture effective dose. So at least it was quantitated in some way. To repeat the clinical studies, as I mentioned, the Louisville Metro Public Health and Wellness Laboratory here in Louisville, our local public health lab, was also doing COVID-19 testing using the CDC protocol. And so they provided us with 25 known positive, quickly frozen NP specimens and 25 negative to complete our clinical validation. We didn't have to do 30 of each of these because the FDA allowed us to use our first 5 negative and first 5 positive NP specimens tested at the State Public Health Laboratory in Frankfort to count towards our total of 60 clinical specimens. So I wanted to show you some data. So when we did repeat our limited detection study using the heat inactivated viral culture fluid, we found that this LOD that we determined was good because it was reproducible in 24 of 24 replicates. As I said, the 25 we compared that were positive and 25 negative from the local public health laboratory, we got 100% agreement. But I did want to show you the data of how we determined the limit of detection. So we started with undiluted heat inactivated viral culture media from Zeptometrics and got really low CT values for both the N1 and N3 target. We found that when you have very low CT values or a high amount of virus present, it will compete with the RNase-P when that's not detected, but our assay was set up that was acceptable as a positive result. Then as we did tenfold dilutions from the undiluted source, the CT value increased by 3 to 4. It isn't perfect because it's a multiplex assay, but it pretty much reasonably followed the typical dilution you would see when doing tenfold dilutions of a control material. And so at this level, we were able to detect all of our replicates, giving us a 33.6 CT value. And by the time we got to 1.5 times 10 to the minus 1 tissue culture infective dose per mil, we could only detect it usually 1 out of 3 times for our replicates. So we stuck with 1.5 times 10 to the 0 TCID 50 per mil as our set limit of detection. And the CT values were pretty similar for both targets, and the RNase-P internal control was very stable for us. I also wanted to show you, although I know it's small, that for the 25 positive specimens we compared with this local public health laboratory, our CT values were slightly higher because it's multiplexed, and theirs are individual reactions, so they get a little bit better sensitivity than we do. However, they were very comparable, and 25 out of 25 agreed over quite a range of positive CT values. So at this time, I wanted to focus on both the benefits and the challenges we found using the Luminex ARIES for pandemic response. We wanted to look at the pooling process in order to save laboratory supplies that we needed for testing, particularly the Luminex ARIES specific cassettes and the ExoPlus master mix that we used for testing. So we thought if we could test 4 patients using the same materials we test for 1, that would kind of help us during times of shortages. We also thought it would reduce the cost to patients being tested. Since 4 patients were tested at one time in our pooling scheme, then we could charge each patient less or their facility less. Some of the challenges we found as we started the pooling validation was over different periods of time, we were seeing well over 10% positivity rate, which is really not suitable for pooling. You need to have less than 5% positivity in your. The time to create and document the pools by our laboratory staff was not insignificant. So they had to take an aliquot from 4 different patient samples carefully, put it into a new tube, and document which samples went into that larger pool so that if it turned out to be positive, we knew which samples to go back and test individually. So that was a step that took some time. We also found, as I'll show you in the data, there was some loss in sensitivity when we pooled compared to individual tests, and I will show you that data. And so that helped us kind of make a decision about when and if we should implement pooling. So the process we used for specimen pooling, and we followed the FDA's template for this as well, we compared undiluted specimen test results to pools of 1 to 4. And these, again, were all NP swab specimens. So when we looked at our positivity rate, when we tested 48 known positives with varying CT values, we found that both targets were detected 93% of the time. We had a category called presumptive originally, in which one of the targets was detected, and we still included that as positive. If only the RNase P was detected, then it was considered negative. So these were all supposed to be positive. So tested individually, 48 of 48 were positive, 100%, which is great. So what did we see when we pooled 4? Well, we dropped down to 68 or almost 69% were detected, or 15% were detected as a presumptive, but unfortunately 16%, 8 of the 48, were not detected. So overall, what we saw was a drop from 100% detected to 83% detected in a pool of 4. And of course, when we looked at 80 negative samples that had been pooled, we had also 100% agreement. So if they were negative individually, they were also negative in a pool of 4. Another requirement of the FDA, if you were validating pooling, was to drop back 1 specimen. So instead of doing a pool of 4, we did a pool of 3 specimens and went through the same process, although not with quite as many specimens. It wasn't required, so we did the minimum required to save resources. So when we looked at pools of these samples, we had 100% detected. Again, 92% of them, both targets were detected, and 7% of them, only one of the targets in the RNase P were detected. But overall, 100% were detected as expected. When we dropped down to a pool of 3, mixing 1 positive sample with 2 negative NP samples, then we slightly improved our overall detection rate to 88%. But we still missed about 11% of them in the pool. Another requirement of the FDA was to do some statistical analysis, which we had our statistics group help us with. And so they asked us to do linear regression, looking at each target, the N1 and the N3, in individual tests versus pooled test. So when we looked at the N1 target, and I'll show you graphs for this, the mean difference between the N1 and the N in the individual test and the N1 in the pool was about a 2 CT unit difference, which was statistically significant. When we looked at the N3 target pooled versus individual test, it was similar. There was a difference of about 2.2 CT value units, and this was statistically significant. So essentially, when we went to the pooling, there was a shift of about 2 CT values. So this is what the data looks like in linear regression when we compared the pools of 4 patient samples. The pools are along the y-axis, and the individual tests are along the x-axis. And so if they were perfectly aligned, they would be along this dotted line. What you can see is there is good correlation, but there is a shift. Similarly, for the N3 target, looking at the pools along the y-axis and the individual tests for the N3 target, again, we see a correlation, but there is a shift with the pooling process. So in summary, I just hope that this story illustrates how the ARIES system has really been invaluable to our laboratory in developing PCR-based testing for our community in Louisville and for responding to the pandemic. With the data gathered using the FDA EUA template for both individual testing and pool testing, we were able to provide timely and accurate results for SARS-CoV-2 to a variety of populations. So as I indicated, we tested healthcare workers, we tested inpatients, we tested people coming to the emergency room with symptoms, we tested preoperative patients, we have tested long-term care facility residents and staff who take care of them. We've also tested employees for large business organizations in our community. So the benefits of the ARIES footprint, the capacity it provides our laboratory, the sensitivity we achieve, the reproducibility, the sample to answer format, and the 2-hour turnaround time all combined have met the needs of our laboratory in a really chaotic time. And I don't want to end the presentation without thanking the members of our team, our expanded team, because without them, we couldn't have achieved and been so successful with this laboratory developed test. So I'd like to thank Dr. Subi, Laura, Sabrina, Jennifer, Chet, Daniel, 2 members of our biorepository team, Bridget, who we confiscated from the travel clinic and turned her into a laboratorian, Holly, Alex, and Karen, our temporary staff that helped us with evening and weekend work so that our regular staff could have some time off, Dr. Ramirez, our division chief, and Dr. Carrico, who runs our travel clinic, with their guidance and support. They really helped our lab be successful in testing these different populations over time. And then I'd also like to thank the Luminex technical support team, Kim Anderson, Matt Phillips, and Aaron Benfield, who were just really great about sharing information they learned from their other users of ARIES, and were just really great about sharing information to keep us from reinventing the wheel. We also had a lot of excellent administrative support from research coordinators in our division to help us with the massive amount of data entry we did when we scaled up production to meet the needs of the pandemic. So I'd like to wrap up the presentation by sharing the resources that I've referenced during this presentation. I shared the FDA template that we use for molecular diagnostic testing for coronavirus. I've shared the white paper, which can be found on the Luminex website, the work we did with 4 other laboratories who also use the ARIES platform. And then I've shared some papers that explain how we validated the use of the ARIES PCR process for research, for example, detecting Streptococcus pneumoniae in urine by targeting the LYTA gene, as well as the papers we published validating the atypical pneumonia panel, the tick-borne diseases we test using whole blood or liquid anaplasma, as well as the pneumocystis UVCI assay on the Luminex ARIES platform. So with that, I'd like to thank you for your time and attention. If you have any questions, feel free to reach out to me or a Luminex support person. Thank you.